everyone. Welcome to the end of 2022. I can't believe how fast this year has gone, but we're looking forward to next year, and these are the guideline updates. We're finally to the place where we've kind of got them in place. We're just doing fine-tuning revisions now, and gonna review today the things that are gonna be new for 2023. So I've got some exciting things to talk about today, and then some minor tweaks and revisions too that I think will be helpful. Everything has been geared towards making your job easier and better. So hopefully that is the case. We've had a lot of asks for input on these, and I appreciate anybody who does give feedback. It's really helpful. At the end of the day, these guidelines are really to help you do your job. And speaking of doing your job, I just want to be the first to tell you, if you haven't heard it lately, thank you. You guys are doing an absolutely excellent job in the field. I feel like this year we've had sicker patients, more sick patients than ever. Shootings, stabbings, overdoses, cardiac arrests, respiratory distress, pediatric illnesses. You guys are doing fantastic. We're one of the busiest EMS agencies and metro areas in the country, and you guys are making it happen, and you're giving excellent patient care. So I just want to say thank you for your hard work. It's recognized, it's appreciated, and you guys really should be proud of yourselves. You're doing an excellent job. As we look forward to next year, these are the big announcement is we're going to have 3 new medications. Droperidol is an antipsychotic medication that we're going to be getting a special skill permission to use because it's not in the state scope of practice. It's driven by a drug shortage of Versed, but we'll have another alternative for sedating agitated patients, which I think will be nice and help us do our job safely and keep our providers safe, ideally, and patients safe as well. And then we're also moving to amiodarone. Again, a lot of these are driven by drug shortages with lidocaine. I'm hoping amiodarone will be easier. And then Levophed as a pressor. And we'll talk about each of these in depth, starting with droperidol. So in the same kind of class as Haldol, if you've heard of that medication before, it's an antipsychotic, so it helps with agitated patients. It doesn't help in alcohol withdrawal. It doesn't act on the same receptors as benzos. Alcohol withdrawal still will need a benzo, so Versed would be ideal there. But with our excited, agitated, intoxicated patients, droperidol will be a very nice option. The scoring is going to be listed on the Behavioral Severity Index, so you can pick your sedative of choice. Your choice will be droperidol or Versed. You can use either. The nice thing is you can actually use both too. If you find that one's not effective fast enough, you can mix your antipsychotics and your benzos, and sometimes the two of them together result in a nice effect of a very much calmer, more cooperative patient. The dosing is going to be based on your BSI scoring. It's going to range anywhere from 2.5 to 10 milligrams. You can give it IM or IV, which is also nice for if you can't get IV access on someone, you still have the IM option. Really important here is after your patient does get sedated and is calmer and a little more cooperative, and you're in a place where you can continue to provide good patient care and move forward with your treatment plan, it will be important to get a 12 lead. And there was some concern in the past. In fact, some of these antipsychotics had a black box warning for prolonged QT intervals. Hasn't really played out to be truly the case, but still a concern. So after we give patients droperidol, we are going to need to get a 12 lead. Some of the evidence for droperidol is very well studied, very well documented. There's other big cities in the country that are using this as a sedative for agitated patients. Here's a nice study that was done in the pre-hospital setting that says actually with droperidol compared to benzos, there were fewer adverse events, a shorter time to sedation, which makes everybody happy, right? And then fewer requirements for additional sedation. So droperidol is very effective. It's a faster onset. It's easy to administer. The doses are similar to your Versed, and it's very effective. And here is another study that was a randomized clinical trial comparing actually Versed to droperidol. This one was done in the emergency department, but what this one showed is there was no difference in adequate sedation for these patients, and actually that Versed had more of a likelihood of needing airway intervention. So droperidol tends to have less respiratory depression, which is another nice consideration when we have options for chemical sedation. And one last study that's important, these are definitely not all of the studies that have been done, but 3 of the most, I think, critical to us deciding to incorporate this into our guidelines. This one talked about the safety of it. I had mentioned the concern for the prolonged QT, and this one actually looked at that, and there was really no evidence. When they looked at thousands of charts, there was no evidence of prolonged QT being a factor here, even though that was the concern with the black box label. So the way that we're going to approach this is that concern is still out there. It's still in all of the tests that people take. And so, these patients that we're sedating, it's really hard to even get a set of vitals on them, right, until we get them a little calmer and more cooperative. So go ahead, sedate them first with whatever your agent of choice is, whether that's droperidol or Versed, and hopefully you'll start to get more familiar with using this medication. But it's going to be next to impossible to get an EKG before you give it. So after you give the medication, just remember, please try to get a 12 lead afterwards so we can document what that QT is. And remember, if it's too long or you see them having PVCs, magnesium, it's okay to give magnesium. That will help with that long QT. All right, so very excited to have droperidol rolling out on the streets as soon as we get the special skill approved. The next transition that we're going to do is amiodarone, and this is due to a national shortage of lidocaine. I know we've been using lidocaine for a really long time, but when we started to look at this shortage, it led me to ask myself, well, what is the downside of amiodarone? And I really couldn't come up with one. It's a little bit cheaper. The dosing is easier. It's the antiarrhythmic of choice in the hospitals. So when we get there with our post-ROSC patient, we've given lidocaine, the hospital's going to transition to amio anyway. So it just makes sense for a system if we're already giving the amio in the field. And then really there's a danger with lidocaine in either a TCA overdose or hyperkalemia because of the sodium channel blocking effects, and amiodarone doesn't have that. So amiodarone is actually a little bit safer in arrhythmias that are caused by TCAs or hyperkalemia. And there's less math. So 300 if you got 300 milligrams if you've got a patient in VFib or VTAC, and then you can do 150 IV or IO over 10 minutes for a more stable VTAC. So hopefully this will be a good transition for us and make your life a little bit easier out there and be better for us as a system. And then the next point to emphasize here is more of an emphasis on Levophed for some of our different types of shock. We still want to use epinephrine. Epinephrine is absolutely still the pressor of choice for anaphylaxis, and I really do like it in symptomatic bradycardia. Think of epi as kind of a chemical pacemaker, right? It's going to increase that inotropy, increase your heart rate, increase your blood pressure. So those are the two situations I can think of where epinephrine would be the best choice. But for most of our other types of shock, really there's a lot of emerging evidence that Levophed is very effective. It's good in cardiogenic shock, and it's especially good in our post-ROSC patients who have a heart that's maybe trying to get back to beating again and may have just had a STEMI or an arrhythmia or whatever. Levophed is really going to be the pressor of choice there, and it's also the pressor of choice in septic shock. There's some good evidence for this as well. These are just 2 of the articles that I pulled, but of course there's much more evidence out there that this works. This is a look at epinephrine versus norepinephrine, specifically in post-ROSC patients, and what they found is that norepi actually had improved mortality compared to epi after patients achieve ROSC. And I think part of that is that epi itself can be a little arrhythmogenic, cause another episode of VFib or VTAC, and it's also so potent that those tiny little vessels in the brain can get constricted. And I think there's concern that epi may cause some hypoxic injury to brains where maybe Levophed isn't as powerful for those smaller vessels, but it'll still increase blood pressure and increase perfusion. So this was a nice study showing increased mortality post-ROSC. And then here's another one. This was a review article that was done in Current Opinions in Critical Care. And again, it just came out re-emphasizing that the preferred pressor in cardiogenic shock is actually Levophed. So please get familiar with how to use that drug. We have a nice reference sheet in the guidelines for you on how to make a drip, how to do the dosing, things like that. And just real quick, let's do this together. And the idea behind it is to be as simple as possible. So whatever your concentration of your drug is, you start with your drug, and hopefully you're picking Levophed, right? That's the one we want to learn. This comes in 4 milligrams per 4 ml. And if you look here, you're going to have 1 milligram and 1 milliliter, right? So you pull out 1 milliliter of Levophed, and you can put it in a 250 underfill. Or if you are using epi, which is fine, you want 1 milligram. And so it doesn't matter if your concentration is 1 to 1 or 1 to 10, whatever that's going to be, you want to end up with 1 milligram here. Does that make sense? I hope so. So we see that 1 milligram here in the code dose is in 10 ml, so you're going to be pulling out 10 mLs, right? You want 1 milligram. 1 milligram of epi or 1 milligram of Levophed is going into a 250 cc underfill. You're going to attach your 60 drop tubing, and from there, that'll give you a final concentration of 4 mics per ml, right? And then as you do your drips, it's going to get the math. For those of you that are smarter than me at math and want to email me, that's fine. It's going to get really hard to get an accurate drip count much past 10, right? But really, your whole goal here is just to get that patient a blood pressure that's perfusing their organs. And so I would pay less attention to counting drops than like its effect on your blood pressure, right? So this is where you want to start. You want to start about 60 drips a minute. That would be 1 drip per second. See what that does for your blood pressure and go up for there. Much past 10, you're probably just going to be wide open, which is okay. Really, you want to get that patient to a MAP, a mean arterial pressure of 65. Okay, and hopefully that makes sense. If you have questions, please feel free to reach out to either myself or the training staff or the 7/8s or your paramedic supervisors. They'll be happy to help. All right, so that's it for the new drugs, droperidol, amiodarone, and Levophed. And then we have some new guidelines, and these were requests from the field, so hopefully you'll find these helpful. This is COPD has its own guideline now. We pulled it out of the respiratory distress because we see so much of it, and it's kind of a unique treatment algorithm. It's got its own guideline. Really what we want to do, this is every single thing the hospital's going to do, we're able to do in the patient's apartment or house or wherever we find them before they get to the hospital. So first thing you want to do, if you've confirmed that it's COPD, which would be, remember your high end tidal, your shark fin waveform, showing an obstructive pattern, a known history of COPD with all the inhalers, maybe a baseline oxygen requirement. Once you've confirmed that it's truly COPD, go ahead and give that duoneb. Consider CPAP early. This is going to be your most effective treatment, and give that a minute to work. Okay, you can get your decks on board. Maybe if you're giving it PO, give that before you get the CPAP on their face, so you don't have to pull it off once you get it situated. And then magnesium is a nice option too. So if I'm moving to CPAP, I'm usually giving Dex and Mag kind of as a trifecta after the duoneb. Now, if your patient is truly in respiratory distress and you're very afraid they're going to code right in front of you, you can consider epinephrine, but I really think of this as my nuclear option. A lot of our COPD patients are elderly and they have other comorbidities. They may have some underlying heart disease, high blood pressure, high cholesterol. They've already got pretty sick lungs, and they're probably already hypoxic, right? And all of that leads to a heart that's not super healthy. And if you give epinephrine there, remember, we just talked about epi. It's very potent. It can cause heart attacks, it can cause strokes, it can cause arrhythmias. And so I'm not saying don't give epi in your patients that you truly think are in respiratory failure, but please be cautious about it and make sure you get a 12 lead after you give it, because it's such a strong drug. Really, if you have time and the ability, which I think you do, because you're basically bringing the hospital to these patients, try that CPAP, give it a minute or two to work and see if you can make some headway with that before you jump to epi right away. Okay, and then another just point that I've noticed over the last couple of years, try your best, sometimes they go together and it's really hard to tell, but congestive heart failure and COPD are sometimes hard to differentiate. I tend to rely on my CAPNO for that. If your CAPNO is high and you have a shark fin, it's more likely COPD, whereas if you hear wet lungs and you see more of a med list that's concentrated on heart failure medications, think about that. And CPAP is actually the answer for both of them, so that's nice. That's our best treatment for both the CHF exacerbation and COPD, because a lot of times they'll present with shortness of breath. But what you don't want to do in a heart failure exacerbation is give albuterol. Albuterol is going to make that heart work harder, and you already have kind of a sick, weak heart in congestive heart failure. And if you give albuterol, that's going to make it have to work even harder, and it may make it worse. So just do your best to try to differentiate the two. I'm not asking you to be doctors out there. Just give it some thought before you give that DuoNeb, because not all that wheezes is asthma or COPD. And if it's more of a CHF picture, please hold off on that albuterol. Still give the CPAP, but just don't give the albuterol. It'll be easier on that heart. And for sure, be careful about that epi too. All right. And in an effort to make our CPAP administration, I know it can be kind of difficult sometimes when you have a hypoxic and anxious patient who feels like they're suffocating, right? To put something over their face, they're not going to like that if they're not used to it. We did add an option to give just a whiff of Versed to help calm them down so they'll tolerate that mask a little bit better, because CPAP truly is the treatment that's going to help. And so you can give 1 to 2 milligrams IV Versed. I always am an advocate of starting low, right? Because you don't want to over-sedate them if they're already having respiratory difficulties. But this is a nice option to help with your compliance for CPAP if you know this is the treatment they need and you want to kind of take that edge off of their anxiety. So hopefully this will be a nice tool to have in your toolkit when you need it. Moving on, another new and very exciting and cutting-edge guideline here is a femoral IO for pediatrics. And hopefully you guys have covered this in MOTU or some of the training with our training staff. But we have several instances of failed tibial IOs in very small babies. No fault of our own, it's just the tibia, especially in a tiny baby, is a really small target. And so there's some good evidence out there that the distal femur is a much bigger target, much easier to hit, and actually has higher flow rates than a distal tibia in a pediatric patient. And so incorporated into our guidelines now in pediatrics less than 8, but really as a preferred site in kids that are younger than 1 is going to be a femoral IO. And it's still going to be on the medial side, so think big toe IO, just like your tibia was. You're going to go on the medial side for your femur, about 1 finger width above the patella, and then 1 centimeter to the medial side will help you find your landmark. And what that does, if you look at it from the side, you can see the patella here. If you're going above the patella right in here, you're going to miss that growth plate. So that's why we're going above the patella to the medial side. This is your target, that nice medullary space right there, and it's probably 3 times bigger than that small tibia that you're aiming for before. So no risk to the growth plate if you're going above that patella. And really the key to success here is inserting that needle through the skin until you feel bone. You should feel a hard resistance. And in kids, their bones are a little bit softer than adults, but you should still feel a difference in the resistance there. So you go till you feel bone, and then you start to drill. Don't start drilling until you know that the tip of your needle is against that bone, and that'll really be your key to success there. Okay, and so hopefully, again, the idea behind this is just help you do your job and enable you to get access on those little kids where you really need it. For adults, we've started to emphasize humoral IO over tibial IO. And the reason for this, the way I think about it, is the tibial IO is probably equivalent to a 22 gauge in your finger, right? Whereas a humoral IO, in terms of flow rates and volumes that you can resuscitate a patient with, I'd equate it to a 16 in the AC. Huge difference in volumes that you can resuscitate with. And if you look at the vasculature, it's going directly into the subclavian vein there, right to the heart. And it's just such a short distance to travel in a patient who's having circulatory issues rather than coming from the distal part of the leg. So a much better choice for insertion site here, actually a bigger target as well, and better for resuscitation. And especially as we're looking at starting ECMO again, this will also have access to the patient will be limited to above the chest, and so it's another nice option for our ECMO patients, but just patients in general. I think it does better with volume resuscitation and medication delivery to the heart. So work on your landmarks there. I think we've had some training on this. You can kind of see the karate chops there to put your thumbs over the humoral head and find your target. Another new guideline, this was a request from the field too, is lightning and electrocution guideline. Pretty straightforward questions to ask when you're getting your history. Ask about the type of current, how much current was, when did it happen. Look at the skin for burns. So you want to expose your patients. Look for an entrance and an exit wound. Usually it'll arc through the body, so you can usually find 2 points that will help you know which path that it took, and if it traveled across the heart, then you want to be concerned about cardiac arrhythmias. I'd get a 12 lead, keep them on the monitor, that kind of thing. Be really suspicious for underlying tissue injury. That's a lot of it's basically a burn on the inside that you can't see. And so these patients over time can develop rhabdo. They get a lot of cellular damage. Just because it may not look that bad at first doesn't mean it's not going to develop into something that can be pretty bad. So take them very seriously, suspect underlying tissue injury, pay close attention to that heart, get a 12 lead, keep them on the monitor. And if there does happen to be a cardiac arrest and like a mass casualty incident, these are the patients where we reverse triage. So normally if a patient wasn't breathing and didn't have a pulse, we would call them a black tag and just leave them and go find the patients, the red tags or the yellow tags that were viable. This is different. If you have a lightning or an electrocution MCI, these are patients you want to defibrillate as early as you possibly can, because just because they don't have a pulse or they're not breathing, they do need defibrillation if they have a shockable rhythm early, and they've shown good outcomes with that. So that is it for lightning and electrocution. Another thing to hopefully make your job a little bit easier as more and more people are transporting in our system that's very busy, that we've got a radio report reference sheet to kind of help you consolidate and just remember what to say in your radio reports to the hospital. This is based off the military. It's called a DMIST acronym. You want to give your demographics. So let's say you have a 60-year-old male who is having chest pain, current, no injuries, nothing abnormal on physical exam, vital signs are stable, and then EKG shows sinus rhythm. So very quick, but you want to cover your demographics, your mechanism, your injuries. Of course, vital signs, I can tell you that's the thing they're going to be listening for the most, so make sure you don't forget your vital signs, and then any treatments that you've given on scene. And that'll be in there as a reference sheet. Another thing that we frequently have can get a little confusing, or we get phone calls about our end-of-life care. And so there's a lot of options as our population is aging and we're having more of these baby boomers retiring. They're choosing different things for end-of-life care: palliative, hospice, home health, DNR, advanced directives. Most orders, it can be a little bit overwhelming. And so we have consolidated those into an end-of-life care guideline to explain each one of them. The difference between hospice or palliative care is delineated. Really what it comes down to is if the patient has a new complaint or they've decided they want to go to the hospital, then we'll take them to the hospital. If you want to do this in conjunction with family or with any nurses or staff that may be present, that's fine too. And if it ever gets a little bit gray and you're not quite sure what to do despite what the guidelines say, feel free to either call the EMS supervisors on duty or call consortium to kind of help figure things out, what's best to do for the patient. And at the end of the day, that's all we're trying to do, is what's best for the patient here. So hopefully this will help make that decision a little bit clearer. At least that's the intent. And then one more thing we've noticed from the field, people are pretty good at this, but I just wanted to take the opportunity to say it, is if you have an unstable patient where you're going to need to cardiovert, whether that's SVT, VTAC, but they're still awake, even if you're having to pace, for some reason you're having to use electricity, and usually that reason is because they're unstable, and a lot of times our instability is due to a low blood pressure. I would prefer to see us using fentanyl for cardioversion rather than Versed, simply because usually the cardioversion is going to be quick, right? And fentanyl is quick on and also quick off, so it's not going to have the lasting effects that Versed has. And it also doesn't affect the blood pressure as much as Versed does. So your blood pressure will stay kind of where it's at. It's not going to make it better, probably, unless you fix the rhythm. But Versed has the potential to actually drop that blood pressure, decrease their mental status, last a longer time. And so if you've got a patient that you need to cardiovert, please just consider using fentanyl. I think it's a better option here. You still have the Versed option. If you think that's right, I'll defer to your clinical judgment, but my preference generally would be fentanyl. And then as we are having more of a mental health crisis in communities across the country, there's a new phone number equivalent to 911 for medical emergencies. There's a phone number 988 for mental health emergencies. It's available 24/7, and it is staffed by providers who are mental health trained experts and can speak both English and Spanish. So it's a very nice resource. I kind of think of this as a telephone mobile crisis team. They're trained in evaluating these patients, asking the right questions, and I find them as a really good resource for our lower acuity psychiatric emergencies where we're not quite sure if they meet criteria for forced transport or if we can leave them on scene. And I know we all get a little bit nervous if we have maybe a suicidal patient that we're leaving behind. This is a really nice resource for those patients. And I would encourage you, one, you can always call Consortium if you need help with forced transport for psychiatric emergencies. But two, if you want to, you can stay on scene. And I would encourage you to stay on scene. Have the patient call 988, tell the provider the story, and then tell your side of the story, right? So you can hear what the patient tells them, add any supplemental history that you have. And these providers say that they can keep patients on scene 80% of the time. And so it would save you from a transport, save the patient from having to leave their home, and get them set up with some care in the outpatient setting that would be very appropriate for whatever their needs are. There is a chance that based on the interview with a mental health provider that patient will need to go to the hospital, so that's why I'd encourage you to stay. There's that 15 to 20% chance that you are going to end up transporting. So just hang out there, be part of that conversation with the provider, and then hang around in case you do need to transport. But hopefully they'll be able to get that patient to more appropriate care in an outpatient setting and keep them from having to have an ambulance transport and an emergency department visit. Okay, just some little minor changes that you may notice. Excited delirium is no longer a term that is used in popular vernacular. It was associated with ketamine use and not really a clinical diagnosis. And so we've changed the term excited delirium to I think it's delirium with excited behavior or something like that. So we basically moved the words around, but you won't hear anybody referring to excited delirium anymore. And this is usually in the instance where we're talking about using ketamine for severely agitated behavior. One other thing that's hopefully helpful, especially as we're having more basics and intermediates in the system with our transport agencies, is no longer requiring a medic to ride in if a patient is sedated with either droperidol or Versed. We really just need two providers there. It doesn't have to be a medic, so hopefully that'll keep more of our medics on the street. We still need an extra set of hands to ride in with, but it doesn't necessarily have to have a medic license. And then we clarified some of the language for forced transport criteria, and we've added pediatric dosing to the behavioral severity index for sedating children who are agitated. And this is cases of severe agitation for children. Hopefully it's a very rare circumstance, but it does happen every once in a while, and wanted to add that to your toolbox in case you need it. We have updated the pediatric dosing charts. This is a nice Broslow reference with all of the drugs that we carry, and will hopefully help you have to do less math in stressful situations. It's there as a tool if you need it. We've also updated the hospital capabilities chart so you can know who takes pediatrics, who doesn't, who does ECMO, who doesn't, who takes strokes, who doesn't. Ideally, as more people are transporting, it'll help you figure out the way to get the patient to the most appropriate hospital with the treatment that they need. And then a couple notes that we've seen over the last year, and this is kind of a sad one, but want to bring it to your attention because we can make a difference here. With the increasing fentanyl availability in the streets, we're seeing more pediatric patients who are coming in contact with fentanyl, whether that's secondhand smoke or taking a pill, or who knows how they're being exposed, but they're being exposed. And we probably see this once or twice a month for the last 6 to 8 months. And they don't usually come in as an overdose, and they don't always look like adult overdoses do. Sometimes they'll be called in as a seizure, sometimes it'll be a choking episode, and you get there and the baby just doesn't look right. If you find yourself in that situation and the story just doesn't really add up, please ask yourself, could this be a fentanyl exposure? And we've had these exposures in babies as young as 2 or 3 months. And so, especially in these ones when they're looking like they're unresponsive, they're not breathing correctly, they're cyanotic, maybe they are foaming at the mouth, consider giving Narcan here. These babies aren't addicted. Narcan is not going to hurt, and it may help. Okay, so please consider that. The dose is going to be 0.1 mg per kg. You can 0.4 would be the minimum. IV, IM. Actually, I would prefer IN. Sometimes if the babies have a runny nose, it's hard to get the medicine actually in. So if they're decreased level of responsiveness enough, just go ahead and give them the shot, because then you know it gets in. You can go up to 2 milligrams. You can't give too much, but give it a try. 2 things to remember, though. We don't give Narcan to babies who are just born to narcotic-addicted mothers. So remember, we don't give it for neonatal resuscitation. If you have a baby who is just born and is not breathing effectively, you just warm them, dry them, stimulate, give your positive pressure ventilations, and keep them warm. Don't give Narcan there, because it does cause problems with newborns. And don't give Narcan in cardiac arrest. At that point, if they've stopped breathing to the point that their heart has stopped, Narcan's not going to restart the heart. So what you need to focus your efforts on there is compressions and defibrillation if it's indicated. And then please remember, too, with the fentanyl epidemic that we're facing, we have leave behind Narcan. So if you give someone Narcan, an adult who wakes up and decides to refuse transport to the hospital, go ahead and leave some Narcan with them that they can give to friends or family to hopefully treat an overdose in the future, just to try to make an effort to decrease some of the mortality out there associated with these fentanyl overdoses that we're seeing. Please just focus on fundamentals. One of the things I've noticed in trends over time with our cardiac arrest, we tend to have longer pauses as we're placing the Lucas. So remember, one of the most important things we do in cardiac arrest is continuous chest compressions. And this is a nice visual depiction of why that's important. So we're basically, when we're doing chest compressions, we're pumping for the heart, right? We're circulating blood. We're taking over the role of the heart to circulate blood to all the organs. Well, it takes a little while to build up enough compressions to generate a pressure to get forward flow. Well, the second that you stop compressions, you start right back where you were, trying to generate forward flow again. And so the longer that you have a pause in compression, the longer those end organs are not getting blood flow. And so that's why we do continuous compressions. But I would ask you to please be very vigilant about not pausing compressions for more than 10 seconds. And if you can do it for less than that, please do. And if it takes 2 cycles of compressions to get that Lucas in place, like maybe the first cycle you get the backboard in, and the second cycle you put the top on and get it going, whatever it takes, but please realize that compressions, honestly, next to defibrillation, are probably the most important things we do in these resuscitations. So please minimize your compressions, the interruptions in compressions. And then speaking of cardiac arrest, we're going to be starting mobile ECMO at the beginning of the year. So please just make sure to know your checklist, run your checklist. If it's a person between the ages of 18 and 75 with an initially shockable rhythm or cardiac ultrasound showing activity in PEA, a high enough end tidal, and not a respiratory arrest, please keep ECMO coming to the scene. And more to come on that. We're starting training now, and if you have questions, please feel free to reach out about this, but they will be out in the streets starting the beginning of the year. Documentation is important. We use this to monitor trends. Please use for procedures or any meds that you give, make sure you're using the drop downs. That's how we can gather data for our system. And it really does help us to monitor trends. It was very important when the fentanyl epidemic first started a couple years ago. EMS is always the first ones to notice it, and we were able to provide some information to the Department of Health and the Poison Control Center. And so the more you can use these tabs to help us gather macro data, the better able we can do to take care of our community. And then just a quick note about some of the studies we have going on in the system. We still have the cerebral oximetry study going on, so if you can get that on as early as possible for those of you that have it on your units, put that monitor on the forehead, plug it in if you can, gather that data. We're almost done with the data collection phase. You may start to see these pupil measurements out there that are going along with the CPOC study. They measure reactivity and constriction of the pupils and are really kind of cool. You'll see them carried on EMS supervisor vehicles. Some of the physicians have them, the fellows, and the 7/8. So if you see those, ask about them. They have a little chip inside that measures reactivity of pupils, and the whole point of all of this is to understand how we're doing in terms of perfusing the brain, because those are the patients that have the best outcomes, obviously, after cardiac arrest, and how we can use these tools to determine who's going to have the best prognosis in our cardiac arrest. So really cutting edge stuff, very exciting. Feel free to ask questions, or I'm happy to talk about it too if you want to. But these are two of the studies that we're doing that are pretty cool. And that is a lot, but that's all I have for you. So please feel free to reach out if you have questions. But I just, again, want to just thank you for all that you do and the excellent care that you take care of our patients.